Thank you, and welcome to the FLaNET meeting. We have Daniel Anaya, our main neuroendocrine tumor surgeon. Thanks for joining. And Rebecca Grillo, are you a nurse practitioner or physician assistant? I forget.
Physician assistant.
All right. And they do a lot of our surgeries on neuroendocrine tumor patients. So I guess just to get started, can you tell us a little bit about how you see the role of surgery for well-differentiated gastrointestinal neuroendocrine tumors? It's a little bit different from most cancers.
Sure, we were going to start out with a few slides, if that's okay.
Yeah, of course.
And everyone can see my screen if I share?
Yes, go ahead.
Okay. Okay. Everyone can see that okay?
Yes.
All right. Thank you for having us. First of all, we appreciate the time to offer this education for you. We're going to start off just going over some neuroendocrine tumor sites, the types of neuroendocrine tumors that we see, different considerations for treatment approach, and individualized approach from a surgery standpoint. Okay, so our first slide here just talks about the diversity of neuroendocrine tumors. So we have different sites of primary tumor sites. Those can be found in the lung, pancreas, small intestine, rectum, colon, or minimally in the thyroid, kidney, cervix, and ovary. Those are the green dots. The little white dots are areas of types of different metastasis, in other words, where these tumors can spread. So this is the picture on your left. The one on the right is just showing different types of primary tumors where the majority of them will likely spread when and if it spreads to the liver. So this classification is important from a surgery standpoint. The World Health Organization had previously, prior to 2010, really referred to these types of tumors as carcinoid tumors. So you may have heard that term when talking about this type of tumor. In 2010, they did a new classification where we talk about low-grade neuroendocrine, intermediate grade, and grade 3, high grade. Those are based on your pathology when you have either a biopsy or surgery that removes these tumors. Those grading system is based on this Chi-67. And again, that's a little in depth, but you may have seen that on your pathology report or discussed that with your surgeon or medical oncologist. So this is how we grade those. Let's see. So why is this important? Is because it also helps determine your treatment plan as well as surgery. So this next slide, I know it's very busy, but I really like the title of the slide, Complexity and Care, because when someone comes to us from a surgery standpoint, you can see all these different pinpoints on this slide that we have to evaluate. You know, is a patient asymptomatic, meaning no symptoms? Do you have symptoms like diarrhea, flushing? Are you having pain related to these types of tumors? Where is the primary? So we had went over this those types of primaries on the first slide. Is it in the pancreas? It is in the small bowel. What grade is it? Are we looking from a curative approach? In other words, can we take out all of the disease or are we trying to remove some of it? Okay, so when you come to us from a surgery standpoint, this is everything we're kind of putting together in a picture to determine your best plan of care. Also, from a standpoint, we look at patients' age and comorbidities, meaning heart disease, hypertension, diabetes, stroke, that kind of thing. So I'm going to turn it over to Dr. Anaya for the next slide.
Yes, thank you. Thank you, Dr. Strosberg and Taima for the invitation. It's great to be able to be here sharing some of the things that we do with patients. You know, that's really the reason of how we do everything, and we hope to be able to clarify a few concepts for you. We basically don't want to bore you too much with this. I think there's maybe 2 other slides, but I think this slide, you know, it's complex figures and everything, but the bottom line is that, you know, the way we measure, you know, the possibility of cure or the success of a given treatment for neuroendocrine tumor, for any cancer in general, is when we try to cure you or to prolong your life, we want to see with different treatments how much do we get out of that. And we always talk about neuroendocrine tumors, even with a stage 4, meaning even when they have left the primary tumor and metastasized to distant sites, most commonly liver metastasis. With any type of tumor, that's usually not a very good prognostic sign, and very rarely curative, and very rarely the ability to prolong life beyond 2, 3, or 4 years, depending on the type of cancer. For neuroendocrine tumors, it's very different. In patients with neuroendocrine tumors that have a stage 4 with metastasis to the liver, there's many different treatments. And I put here some of the results of surgery. When you compare surgery with any other treatment that exists, the likelihood that you can live much longer is significant. And so, in the past, maybe 10, 20 years ago, most of the reports said that when you had surgery, you could live in average about 5 years. Some people more, some people less. But now we know that patients, even with a stage 4, when we do surgery, we can observe results that are, in average 10, 12 years. And the proportion of patients that are alive at 5 years has been extended to almost reaching up to 90%. That is with surgery, but also with the combination of other treatments, including chemotherapies, including liver-directed therapies, and all of that. So, the bottom line here is surgery. When you can do surgery, surgery is the ideal treatment. Not everybody can have surgery at the beginning. And even when you do surgery at the beginning, there's going to be a very likelihood of developing or requiring other treatments. And this is why it's very important to, when you have a neuroendocrine tumor, to actually have a team of different specialties that can provide you the best care by choosing the best timing for one treatment versus another, and making sure that all the different specialties are looking at everything. Next slide. These are some cool pictures that we have that show some examples of what we do here. On the left-hand side, you can see a CT scan, and the gray organ that is being outlined there by Rebecca is the liver. It should really be half of what you see there. The black spots, really black spots coming down from the liver, is a very large neuroendocrine tumor. And this patient is a patient that lives here in Florida. We saw her after she came here for almost like a third opinion. She was told that these were too many tumors and that she wouldn't be able to have any type of meaningful treatment or surgery, and that she should essentially get her stuff together because she didn't have a lot of months to live. We actually did some really cool pictures with 3D reconstruction. We actually did 3D printing of her liver. All of that, as you can see, allows us to see the relation of the tumors with vessels. The blue things that you're seeing there are vessels inside the liver that tell us how much we can remove. And we actually were able, in 2 different surgeries, remove all her liver tumors. And she's now maybe like 3 years out, living a completely normal life with follow-ups and everything else. So that's just one example. Imaging is essential. So, you can see here how we use not only the typical imaging, like could be a CT scan, but we also do a lot of ancillary software that we have that allows us to really plan if surgery is appropriate and plan the surgery the right way. Next slide. I mentioned that, imaging is critical. On the left-hand side, you can see a typical CT scan. And on the 2 right-hand sides, you can see what's called a PET dotatate, a PET scan that is specific for neuroendocrine tumors. And you can see on the one in the middle that there's a very bright spot right there where Rebecca is pointing that shows a small bowel tumor that has metastasized to the lymph nodes in the mesentery. And on the right-hand side, you can also see 2 spots in the liver that are very bright, and that confirms that these tumors are tumors from neuroendocrine tumors. You can see on the left-hand side that those tumors on the liver, you can't really see very well. So sometimes we do a CAT scan that doesn't show liver tumors, and we oftentimes need to do a PET scan or an MRI that allows us to see all of this and put everything together with radiologists, with nuclear medicine doctors, oncology surgeons, and everything to really come up to the best plan. So always really multidisciplinary care is essential, and appropriate imaging is essential to come up to the best treatment option. I think this is the last slide. So hopefully that kind of laid the baseline to have some additional, some baseline information, and we'll be glad to answer any questions or have Dr. Strosberg lead the discussion.
Thank you. That's fascinating, that 3D model. When did you guys start doing that?
We started doing that maybe 3 or 4 years ago, and we do it for all patients that have liver tumors and are going to have surgery. Not for all patients, but patients with different types of tumors, that when it's applicable. And one of the things that we have learned, that we've been continuing to develop this, is that particularly in patients with neuroendocrine tumors is very, very useful. Because in patients with neuroendocrine tumors usually have either very large tumors, like the one I showed, or multiple tumors. And those multiple tumors can be close to some vessels or to some structures. And patients really love it because they actually see the model that you saw there. They can hold it in their hands, and that's not a model. It's actually their liver with their tumors, with their vessels. And it's wonderful for them to be able to see it and to understand why is it that in this case we're recommending surgery for this, but not surgery for that. So yeah, I think we're probably the only site in the US that is able to do this, and we're working towards developing a way in which we could actually have patients come and go home with their liver model so that they can really understand and study this in more detail.
So let's talk more about debulking. The medical term for that often is cytoreductive surgery, and we're usually talking about the liver, which is an organ that can regenerate. So talk to us a little bit about criteria for debulking surgery.
Yeah. The neuroendocrine tumors are very unique, and I think what I tell patients all the time is, it's of course not good to have a stage 4 when you compare it to having stage 1. But like I mentioned in the slides, having a stage 4 neuroendocrine tumor is not a death sentence. You can live with it for many, many years, but you have to make sure that you have the appropriate treatment at the appropriate time. The second thing that is a little bit different to other cancers as well is, in general, when you have other cancers, the surgical treatment is geared to removing all the cancer. And one of the criteria to actually do surgery is if you can remove all the cancer. If you cannot, then surgery is never an option. For neuroendocrine tumors, it's different. For neuroendocrine tumors, we have learned, particularly when we're talking about the liver, that debulking, meaning removing a good proportion of the tumors, even if it's not all the tumors, is associated with a significant benefit, both in control of the symptoms and also in prolonging your life. In general, what I tell patients is, if we can debulk at least 70% of the tumor mass, and every tumor is different, right? So the example I give, if you were to have 10 tumors the same size in the liver, if I were able to remove 7 of those, that would be ideal, to really obtain a benefit. We have a lot of different software that we do to measure those volumes and estimate that. But in addition to that, you want to do it in a way that you don't remove a lot of liver, because if you remove a lot of liver, your surgery becomes bigger and it can really have an effect on you and on your well-being. Having said that, in cases that we actually have to remove a lot of liver, like the case that I showed, that patient, we had to remove 80% of her liver. And the liver, like Dr. Strosberg mentioned, is really the only organ that regenerates. And what I tell patients all the time is, if we have to cut your arm, the arm is gone and it doesn't grow. But if we cut your liver and your liver is healthy, it will grow, and it will grow about 80% of what it was. And usually it will grow over a period of 4 weeks. So it grows really, really fast. So we use that to rely on the liver's ability to be able to grow. And sometimes when, for example, in that patient that we had to remove 80% of the liver, we know that 20% is not enough. So we do things before surgery to make that 20% grow. And then that happens over four weeks after we do a very simple procedure. And then we can do the surgery. So to answer your question in regards to indications, we usually, are very aggressive in proposing surgery because it controls symptoms and it improves your survival. When we can obtain a meaningful debulking, meaning over 70%, and when doing that, we are able to maintain a good amount of functional liver so that you can recover from that.
Right. And it's important to, I think, explain the reason this works, particularly for relatively slow-growing neuroendocrine tumors, is because in most other cancers that are more aggressive, by the time you're done with your surgery and recovery, many new tumors will have formed. That's not necessarily the case for neuroendocrine tumors. So you can do the surgery, the patient will recover, but and remain, in this kind of surgical partial remission. In other words, a lot of the cancer is gone and may take many years to grow back. And that's one of the advantages of this technique in patients with neuroendocrine tumors compared to, say, your garden variety lung cancer or colon cancer, where this doesn't work that well.
Right.
What about surgical techniques? So you can remove a tumor by cutting it, but there's other techniques like ablation where you burn the tumors, and sometimes people use the term enucleation to describe removal of tumors in the middle of the liver. Can you go into more detail about that?
Yeah. So, traditional liver surgery has, for liver tumors, has been defined as something that we go and remove a big portion of the liver away from where the tumor is, so that we get what we call a margin clearance, a negative margin. And that's very important for all the cancers, because if you leave a few little cells of cancer, well, that will come back and it's likely to kill the patient. In neuroendocrine tumors, it's a little bit different, right? We're talking about doing only a 70% debulking, which means you would even leave 3 out of those 10 tumors in the liver, and you would still get a benefit. So getting a negative margin is no longer that important, particularly when you're leaving tumors there. So it's more important to maintain the liver healthy, because you will require other treatments in the future. And we want to make sure that the liver is strong and healthy to withstand those treatments. So rather than doing really big operations, sometimes we have to, like the one I showed, but rather than doing big operations, we really try to focus on something called parenchyma sparing operations, or in this case, liver sparing operations, in which we basically remove the tumors, as many as we can, but preserving as much liver as we can. So rather than cutting away from the tumor, sometimes we try to always do that, but if that's going to include removing a lot of liver, we can do another type of technique, which is called enucleation, like Dr. Strosberg mentioned, in which we don't really go for getting a margin around the tumor, but we actually go and just kind of pluck out the tumor, not necessarily with a margin. Essentially, we're not removing any liver, we're just removing the tumor by plucking it out, and that allows patients to really recover well and maintaining a good enough liver. Sometimes we have to combine that, or rather than doing a big operation, or we can't do an enucleation because the tumor may be very deep, we may be able to actually burn the tumor. And that is almost as good as taking it out. That's what's called ablation. And it's essentially done by putting a needle, special needle, inside the tumor and then burning it with different types of energy. We use microwave energy, radio frequency energy, and that can really be done with minimal effects on the other part of the surrounding liver. So many times we may decide to remove 3 tumors, enucleate 1 tumor, and then burn 2 other tumors to be able to get to that 70 or 80 or 90% while maintaining a good portion of the liver.
And how do you choose whether you need to do a full incision or minimally invasive surgery like
Right.
robotic
So
or laparoscopic?
right. So that's what we call approach. So, there's different techniques, and now how do we approach that? And in general, there's two different approaches for all types of surgery, but as it relates to liver, it's really either doing an incision, like the traditional surgery that we do, in which we that's what we call open surgery. And the other one is what we call minimally invasive, in which we do little tiny incisions, multiple, and through those little tiny incisions, we do the surgery, usually with the assistance of a robot. And we do the resections, and then we make a little incision a little bit bigger through where we can take those tumors out. That is it's a good technique that we have, and we do it for many of our patients, but it has to be good for the right patient. So, for example, if we're going to remove a tumor, like the tumor I showed in the scan, although we can do the surgery robotically, well, we will still have to have a big incision to take that tumor out. So in that case, it doesn't really make a lot of sense to do that. Similarly, I mentioned before, patients with neuroendocrine tumors sometimes have many different tumors in different areas. Sometimes I may go there and remove 10 tumors. So remove 7, enucleate 2, and burn 1. And with the robot, that becomes a little bit more lengthy operation, in which all the benefits are lost by just the amount of how long the operation is, and so forth. So we do have both techniques. We do it all the time, but we do it for the right patient at the right time as well.
And let's switch gears from the liver a little bit and talk about removal of primary tumors. We do that mostly for small intestinal primaries. Can you talk a little bit about that?
Yeah, I think most of I would say the majority of our neuroendocrine tumor patients are very knowledgeable about this. I would say that when we're talking about the primary tumor, I like to consider all the things that you saw on the table, but the first thing that we consider is, number one, where is the primary tumor? And number two, is the primary tumor only there, or has it metastasized? When it's only in the area, in the organ that it started, we always want to do surgery as the primary mode of treatment, because that can cure that patient from that cancer. When the tumor has metastasized, then the considerations to do surgery are a little bit different. Now, jumping into the small bowel tumors, that becomes even more relevant. If we have patients that have primary tumors in the small bowel, and they have not metastasized, we make every effort to try to remove the tumors. There is a couple of considerations here. Most of these patients, even when it hasn't metastasized to other organs, the tumor has metastasized to the lymph nodes that are around the tumor in an area called the mesentery. And that's important, because in that mesentery are where all the vessels that go to all the bowel are. So if that tumor from the lymph nodes in the mesentery becomes too big, it can cause bowel obstruction, but it can also cause decreased flow to the intestine, with a lot of problems related to pain and everything else. So we most of the time do every surgery possible. These are surgeries that I would recommend any patient with this to really go to an expert center, because the type of surgery that has to be done is very, very unique and very, very detailed. And I would also encourage everyone to try to avoid having minimally invasive surgery unless there's really a specific indication for that. And the reason for that is two, and this is very common, and we see this many times. Patients that have a small bowel tumor and have minimally invasive surgery, it's very hard to be able to remove a very large mesenteric mass that is close to important vessels. So sometimes when you do a minimally invasive surgery, you may remove the small bowel tumor, but you don't remove the mass. And that mass is what's going to cause more problems in the future. So that is done more safely in an open scenario. The other reason, and we see this all the time, is that we have patients that the CAT scan and maybe the PET scan show one tumor in the small bowel with one mesenteric mass. And when we go there and we actually feel this bowel with our hands, we find 5 tumors, 10 tumors, different tumors in the small bowel. This is very common. It happens in 40% of the patients. I tend to think that it happens even more frequently. I just had a patient yesterday that had a beautiful PET scan, only one tumor and one mesenteric mass. They asked me why we wouldn't be able to do it laparoscopically, and I said, well, I want to make sure I feel all your bowel along, everything, to make sure I don't leave tumor there. Because if I just go laparoscopically where I can't put my hands and remove that, we may high five everyone, including the patient that, recovered well, little tiny incisions. But maybe 2 or 3 years later, we see tumors that were left there that were small come back and become a bigger problem. And we see this all the time. So the patient yesterday, I took to surgery, and after filling everything, we found 12 tumors. And we had to take much more of the bowel and much more of the small bowel mesentery to be able to really cure the patient from surgery, with the surgery.
And as you pointed out, sometimes we do this even in patients whose disease has spread elsewhere. And the reason for that is also because these tumors can continue, even though the cat, to some extent, the cat's out of the bag, the cancer has spread, but still these tumors in the small intestine and surrounding lymph nodes can continue to cause pain, obstruction, sometimes bleeding. And so it's important to consider removing those tumors, even if the cancer has already spread.
Right. And what I tell patients all the time is, if you're having problems, if you have small bowel tumors and liver metastases, and you're having symptoms from the small bowel, the decision is a little bit more obvious in that you would benefit from having surgery, because that's causing trouble already, and that trouble is affecting your quality of life, and it's likely to get worse and maybe affect your life, and your survival. So that is a little bit more obvious, and I think I would encourage patients whenever they have symptoms of obstruction or pain, even if they have metastases that cannot be removed, to prompt, and ask to their providers about this. It's a little bit more of a little bit more difficult decision when patients have the same scenario of a small bowel tumor with metastases, and they do not have symptoms from their small bowel. Then, you say, well, if this is not going to cure me as surgery for the small bowel, why remove it? And that's a great question. And there's many studies that have been done to look into this. And we strongly believe that if you have that small bowel tumor, at some point that will become symptomatic and start to cause problems. And that, like I said, would significantly impact your quality of life and your survival. But in addition to that, the treatments that will be available to manage those liver metastases that cannot be removed, most of the time get in the way or can affect in a bad way the treatment, the management of the small bowel tumors. So in addition to, preventing complications that may occur in the future, it simplifies the treatment for the liver metastases, allowing many more options to be used without complications from the small bowel. And we believe that all of that together translates into living longer. So while we don't know that removing that small bowel only will increase your life, well, we do know that it will simplify the management for the liver metastases in a way that it will prolong your life, at the end.
Now let's talk about treatment of pancreatic neuroendocrine tumors, both metastatic and non-metastatic. So let's start with small incidental tumors in the pancreas, which we're seeing more and more commonly. Small, under 2 centimeters, low grade, meaning under the microscope they look very unaggressive. Pancreatic neuroendocrine tumors. There are some controversies over, whether surgery should be done or whether surveillance is more appropriate.
Right. Yeah, this is a very hot topic, and it's been a hot topic for the last 10 years, I think. Every Congress or meeting that we go, there's always a session on this. But I think we've come to the to more and more agreement that in patients in which we can be assured that the tumor is small and the threshold is usually 2 centimeters, for sure patients with tumors less than 1 centimeter. And we know that that tumor does not have any markers or any indication that it has an aggressive biologic behavior. And that can be determined by the grade as well as by other different specific characteristics that we can look through biopsies or through imaging. And it hasn't spread. You can have a tumor that is 2 centimeters, but it has spread already, so that's a different story. But it hasn't spread, then the likelihood that that tumor by itself is going to have an impact on the quality of life, on your life or your lifespan is very minimal. So in that case, we favor follow-up to make sure that the third indication to surgery doesn't happen, which is active growth. So if we see that patients have scans, either MRIs, ultrasounds, or CAT scans, and we know that it hasn't spread anywhere, and we know that the tumor remains the same size and doesn't really seem to be increasing in size, then that is even more reassuring that the plan of observation is right. If, of course, the tumor starts to change, then that's a little bit different, and that goes in line with a more aggressive biologic behavior in which maybe that tumor actually will impact your life, and that would be a reason to do the surgery.
So let's talk about tumors where surgery is recommended, non-metastatic and hasn't spread, but is either symptomatic or larger than 2 centimeters. Can you talk to us about the different types of pancreatic surgery?
Yeah. So, the pancreas is a tough organ. It's, when we are training as surgeons, I was training maybe like 20 years ago already, but when we were training as surgeons, they used to say that that's the one organ you don't want to mess with because, it's in a tough location. It's surrounded by a lot of critical vessels. So this is one other situation in which if you have a pancreatic neuroendocrine tumor, I would strongly recommend to go to a place that has a neuroendocrine program, that everybody can weigh in from different specialties, but that also has a high volume pancreatic resection program, because the surgery can be very complex, and it's very, very safe nowadays when it's performed by surgeons that do it frequently at hospitals that do it frequently. So that everybody is aware of what the best things to do are. There's really 2 major types of surgeries for pancreatic tumors, and that depends on the area where the pancreatic tumor is located. The pancreas has essentially 4 different areas: the head, the neck, the body, and the tail. So anything that is in the body or the tail is usually done with a surgery that is simpler, in which we remove that part of the pancreas, sometimes including the spleen because they share the blood supply, and patients tend to recover well without a lot of impact on risk or quality of life or anything else. When it's in the neck or in the head, most commonly, the surgery that is required is called the Whipple procedure. I think this is a word that a lot of patients are familiar with, and it's one of the biggest surgeries that we do in pancreas and liver operations. It's a big, big operation because of what I mentioned initially of the relations of the pancreas with important vessels and structures. It's an operation that requires not only the removal of the head of the pancreas with the tumor, but it includes removal of part of the stomach, part of the bile duct, part of the intestine, to be able to remove everything safely. And then, because we've removed all those organs, we have to kind of rehook them up. So we recreate a new anatomy for your GI tract, for your liver, for your pancreas. And, it sounds like a lot, and it is a lot, but when it's done in expert hands with expert teams, patients do very, very well. And we have, all the resources. You want to go to a place that not only has the right surgeon, the right nurses, the right team, but also the right aftercare. A lot of patients may have changes with the digestion, with weight loss and things like that. And going to a place where he's expert in doing this We have a lot, like for example, here at Moffitt, we have a lot of nutritionists. We have different replacements of enzymatic, pills and things that do to help you have a very normal life with very good quality of life, but it has to be done under the right circumstances.
Great.
That was a long answer.
All right. I have more questions, but I do want to see if anyone participating in the call wants an opportunity to ask any questions. And while we're waiting, Mena, do you have any thoughts or questions?
Yes, I think we had a good discussion about surgical techniques and offering surgery to the right patient at the right time. And part of that assessment is how healthy and overall the whole person is, of course. And Rebecca, I know that we work on this together as a whole team, but if either of you could talk about, rehabbing, if you will, a patient for surgery, what are the markers that we look for fitness for surgery, and can we work on that to make surgery possible? Specifically for the liver, but also just a general overview.
You want to take that one, Rebecca?
Well, I can talk about one of our programs for our older patients that we have. When we see a patient that is 70 or over, we often have patients seen by our geriatrician, and they go over a full assessment to see anything that the patient may need prior to surgery. And then Dr. Anaya has also instituted a prehab for patients here. So they actually do exercises, a whole exercise program prior to surgery, at least 4 weeks beforehand. And since we're talking about different cases, Dr. Anaya had done this for a patient recently that was 89, and he said he felt the best he ever felt after surgery, best he ever felt in his life. So we do a lot to get patients prepared physically, as well as making sure they're fit for surgery, whether it's an echocardiogram, stress test, or certain evaluations, meeting with a dietitian beforehand, making sure their nutrition status is up to par.
Great. I think that, that's part of whole patient care. Thank you for sharing about that program. I have one more question, John.
I will add one other thing is I do have a background as a dietitian too. So sometimes those educations come in our conversations in the room anyway with Dr. Anaya and myself, because that's near and dear to my heart. So we always try to incorporate that whole patient care, nutrition, physical activity, and getting people prepared and up and walking after surgery and, ready to take on the world.
Awesome. When we look at small bowel surgeries and mesenteric resections, how do you set expectations for our patients about how their digestion will feel like, 2 weeks after surgery, 3 months, 6 months, and what's the timeline there? One of the things that I work on in clinic with you also is trying to celebrate the small steps, and that it's a steady improvement, but not overnight. So can you speak to how we can support our patients and what their expectations can be after bowel resections?
Yeah, I think this is very important, and we spend a lot of time doing this before surgery, during the inpatient admission, right after surgery, and particularly probably the first month or so after surgery. And oftentimes when we do this surgery, like I said, there's more than one tumor. There may be 10 tumors, like yesterday, 12 tumors. Or the mesenteric mass may be involving vessels that involve a bigger portion of the bowel. And so many times we have to remove much more bowel than what we would want to. And the bowel has two critical functions. One that are related to this. One, it absorbs water. And second, it absorbs specific nutrients. So the one that really we see affected initially is that if we have to remove a lot of the bowel, it's not unexpected that right after surgery, particularly after the patient leaves the hospital and goes home back to normality, and they start eating normal on their regular diet, and they will start seeing that they're having more diarrhea. And that's because, they've lost a lot of the bowel that was there helping absorb that water. And so all that water is going through and it's causing diarrhea. And we do the surgery in a way that we remove the majority of the tumors, ideally all of them, while preserving enough bowel that this won't become an issue long term. And having said that, it's not uncommon that initially, like I said, there's a little bit of issues going there. So we work very closely right after surgery. And Rebecca, I know, does a lot of this, and our nurses and all of our team in basically seeing patients in clinic, talking to them over the phone. And we have a lot of strategies with escalating medications to try to control that while the bowels are adapt. And the bowels, like the liver grows, the bowel doesn't grow in length, but it does grow microscopically. In the glands that absorb that water multiply in patients that have had bowel removed. So over time, a few weeks or so, the capacity to absorb more water increases, and we're able to kind of de-escalate the need for medications. But it's a very important question, and I think it's important. One of the things that I like to tell patients is that neuroendocrine tumors, you don't want to have any cancer, right? And I don't like to say that, if you had to choose a cancer, choose this one over other. But I think this is one of those cancers that is less aggressive than others. And with that, sometimes patients, this becomes more than trying to cure a patient from cancer, more to kind of managing it like a chronic disease, because patients are going to live for many, many years. So it's like having diabetes, right? You can die from diabetes, but you can also live many years if the diabetes is well controlled. So we want to make sure, because that's the case in this type of cancer, we want to make sure that the quality of life through all that process is good. And that's why that's very important, I think. Rebecca, I don't know if you want to add something to that. You are very involved with all of this management.
I was just going to say, I think just when we reviewed the slides in the beginning, all of those little key points for plan of care for treatment for neuroendocrine tumor is the same as after surgery, especially related to the small bowel. So what works for one person may not work for another. So we can do, different medications and just have consistent follow-up as well as education, keeping diet records, what works for you may not work for somebody else. So I think it's just a big education component and really learning about what works for each individualized patient, because everybody is different.
Absolutely. Well, thank you for very clear explanations. That was great. And, thank you for everything you do for neuroendocrine tumor patients.
Thank you for having us. Any more questions or anything?
All right.
Okay, well, thank you again.
Thank
Thank you
you
for the opportunity.
All right.
Thank you.
Bye-bye.
Bye-bye.